over the next 5 to 6 minutes of the allotted 7 minutes given to me, I will be speaking on a trial that's a CARD trial, which is on Cabazitaxel versus Abiraterone or Enzalutamide in a metastatic prostate cancer. And this is on a setting where they have already been failed to docetaxel, they have been exposed to docetaxel and already have received one of the androgen receptor inhibitors. So the background is, although patients with the metastatic castration-resistant prostate cancer have several treatment options, there are actually few data exist about the treatment sequencing in this subset of patients. In the previous study, I have also suggested there's a partial cross-resistance between the androgen signaling targeted inhibitors that's present. 4 of them are actually present. In India, we use 2 of them and docetaxel. And the androgen signaling target inhibitors, docetaxel, are frequently used in earlier stage of the disease, as the previous speakers have alluded to. We have been starting to use it along with the androgen deprivation therapy. And it is likely that most patients who are considered to be candidates for chemotherapy would have received both of them or in either order, both the androgen signaling the targeted inhibitors. So to address the question of the patients who have been exposed to docetaxel and also have failed one of the androgen receptor inhibitors, whether to give Cabazitaxel versus or to give Abiraterone or Enzalutamide, depending upon which they have been received earlier. So here, these are patient metastatic castration-resistant prostate cancer whose progress within 12 months of a prior androgen receptor targeting agents. The androgen receptor targeting agents could have been given before or after docetaxel, but they should have been exposed to 2 lines of therapy, and there should be castration-resistant prostate cancer. This was named the CARD study design. It was a multicentric randomized open-label study with a 3 years enrollment, and the median follow-up was about 9 months. So the primary endpoints were the radiological PFS, that's the primary resistance, and the secondary endpoints were the OS and the PFS and the PSA response. Sorry, excuse me. The characteristics of the patient, around 33% of the patients were beyond the age of 75 years. So they used the elderly because prostate cancer, normally all the trials have this subset of patients. Around 20% of patients had a visceral metastasis. And at the time of progression of the entry study, the PSA was only elevated around 8% of cases. The radiologically with no pain are around 17% of cases, but there was pain in a significant around 2/3 of cases, and more than half were have the high Gleason score, and M1 at diagnosis were around 40%. So look at it. Just to tell you the timing of the previous androgen signaling receptor before and after docetaxel, around before docetaxel around 40% and after docetaxel around 60%, and that's what is the data of the previous treatment. So looked at the imaging based PFS, which was this primary endpoint of the study. It proved with a significant value in favor of Cabazitaxel with a hazards of 0.54 that it was superior to any of the androgen signaling target inhibitor used. The Abiraterone used the Enzalutamide once used the Abiraterone, and both of them it was superior in favor of Cabazitaxel, 8 months versus 3.7 with a hazards of 0.54. The PFS was also statistically significant, is the hazards again of 0.52 in favor of Cabazitaxel, and the OS was also significant to the hazards of 0.64 in favor of Cabazitaxel versus the androgen signaling targeted inhibitors. The results of the radiological PFS in the subgroup analysis, there was nothing as a subset which we could tell that this is the subset which will not benefit. So every group really had a benefit. It is across subsets that Cabazitaxel showed superiority. For the skeletal events, because majority had a pain and bone mets, so the Cabazitaxel did not reach the median, while the other arm had 16.7 months to the first symptomatic skeletal event. So again, this was a superior in that. Safety, I'm not going to allude into much because we have been using these drugs and nothing new to tell about that. So to conclude, in conclusion, Cabazitaxel leads to a longer imaging based PFS than Abiraterone or Enzalutamide among patients who are metastatic castration-resistant prostate cancer who had previously received docetaxel or alternative androgen signaling targeted inhibitors. Cabazitaxel improved the PFS, radiological PFS, the OS, and also the first sign to a major skeletal event. So what do we take it from? All of us know that the upfront dosi versus Cabazitaxel, the Frustana trial showed that Cabazitaxel was not superior. We also know that the patient with a poor or early lack of response, here it is important for us to remember, this is the editorial which I'm quoting, that this could be a sequencing that all we already knew. There's evidence to that now. Early patients who do not respond beyond 18 months to a hormone receptor inhibitors like enzalutamide or abiraterone, to follow up with the second agent of this group is not the right option. The best option is to go for chemotherapy. What about PARP inhibitors? Because now also we have PARP inhibitors in prostate cancer. To end it off with that, you have olaparib and rucaparib. There are two drugs that are approved. So if you have exposed a patient to abiraterone and enzalutamide, no chemotherapy, the studies of olaparib has been positive. But if you have exposed a patient to chemotherapy and the AR targeted therapy, then rucaparib is the drug as of now because of the evidence it has gathered. So the last point, do we have to look at AR-V7 detection? Yes, that would be helpful. If you have a mutation in this part, then probably you would not be and not looking at a therapy which is based on androgen receptor. And that is what it should be ending up with. You look at the previous progression-free period, you look at the AR-V7, you look at the use of PARP, whether the BRCA mutation or the other mutations which are linked to the BRCA family is there, then you should sequence your therapies. So that's it. Thank you. And I hope I finished in my time. Thank you.